Welcome to the Pharmacists Are In, a podcast made for pharmacists by pharmacists. Pull up a seat and let's get started.
Welcome back, everybody, to another episode of the Pharmacists Are In podcast. My name is Ajit Johal. I'm a pharmacist from Vancouver, BC, and I'm joined by Dr. John Papastergiou. So I can see on Microsoft Teams, you've changed your designation and respectively so. So if you want to hear about John's story of how he became from Mr. John Papastergiou to Dr. John Papastergiou, check out one of our episodes when he talks about his thesis defense in the Netherlands. So, John, we are back with another episode. We've done quite a bit in the vaccine space, and I'm really excited for our next episode because we're going to be segueing a bit into diabetes, which is a huge topic for pharmacy students, like how much of that comprises the PEBCs. And it's just such a massive chronic disease that is getting more and more complicated with all the guidelines that have come out. So, John, I'm super excited to do this episode. And
we've spent the last few kind of talking about vaccination, and I think really it was a really timely topic. But yeah, it's a perfect time to change gears a little bit, and we've got with us probably the busiest guy in pharmacy. I mean. I don't think we even need to introduce you, Mike, but
I wanted to introduce Mike with a story. So, story. It doesn't involve Mike personally, but it involves him as the educating entity. So, I was at the CPHA conference back in Calgary. I think it was in 2016, and I had done a few CEs on travel. And there's a few U of T students that came up to me and said, "Hey, yeah, we've seen a few of your CEs in travel, and obviously U of T students being the more vocal of the pharmacy students, because I think Mike, you're a Leslie Dan alumni as well. Yes, we're all Leslie Dan alumni. Yeah. So one of them pipes up and says, "Yeah, you're like a young Mike Boivin."
Yeah, it won't, Ajit. I'm fine with that.
But it's not a testament to you being old, Mike. It's legacy, and you've done so many educational programs, not just for pharmacists, but for specialists, for GPs, and I think it's a testament to not just the quality of your education, but the diversity as well. So super excited to have you on here, Mike, and we're really excited about today's discussion.
I'm thrilled to be here, guys. I appreciate the opportunity to talk about diabetes, and there's so much going on in the space, so much news, so much that is exciting. The issue is that, and I think that we'll really get into it today, is that it can seem overwhelming at times, but in reality, there are so many little interventions that pharmacists can do. And what I'm really focusing on is little interventions that you can do today that will take just minutes of your time to really change the trajectory of this disease state. So by doing something now, you can reduce the risk of complications for these individuals over a long term. So I'm really quite excited to really address some of the questions that you may have or your audience may have that we can really focus on as well.
It's fantastic.
And I think, Mike, one of the reasons we decided to do kind of the segment on diabetes today is because of the guidance that's come out. I guess there's new guidelines now, and I think that's really, why we wanted to have you here. I know you're super active on LinkedIn, and I remember sending you a message saying, "Hey, like the images you were posting make a lot of sense, right?" So it seems like this area could have been. It could have been, for practicing pharmacies considered pretty complicated, right? With all the new agents, where they fit, whatever. But I thought, when I saw some of the stuff you were posting, it also makes a lot of sense, right? So it's going to be interesting to hear your perspective on that and kind of what's new with the guidance.
Yeah, I think it's actually getting easier now, if anything. So we know, to your point, John, that Diabetes Canada just released both their update in terms of the pharmacotherapy and type 2 diabetes chapter. That was just updated within the last 4 to 6 weeks. And at the same time, if pharmacists are not familiar with it or people that are listening, is that they also come up with a user guide. And the user guide is really practical from the standpoint is that they get practicing clinicians to say, what are the key questions that they have? and then they answer that within the user's guide. So if you have questions that you're looking through the guidelines saying, well, they're talking about all these studies, just go to the user's guide. The guidelines are really specific about studies where the user's guide is, hey, do this. This is what you should end up doing. And it's an easy way to actually implement it within practice as well.
I think Jim might be too young, but do you remember, Michael, I think we were on an advisory board years ago when there was the diabetes handbook that was published a few years back. And it was pretty like easy to use. I mean, they did a lot of work. I mean, some of the challenges was it was a physical handbook. There was no electronic version, but I mean, I remember thinking at that time that, the work they did back then was really tailored towards making it easier for the community pharmacists to make recommendations. And like you said, it seems to be getting to the point now where you could almost memorize all that stuff. It's not even that complicated, right?
Yeah, and I think that we have to remember, like from the time that when that handbook was actually developed to where we are now, is that we know like Ajit is out in BC, and we know in Quebec and on the East Coast that 1 in 3 patients or 1 in 3 Canadians don't have a family physician or primary care clinician. We also know that in the rest of the country, it's between 1 in 4 to 1 in 5. So back in the day, that wasn't the case. So back in 2013, more people actually had access, especially people with chronic disease states like this. So the worrisome is that if we don't take more of an active role with this, that these people are going to fall through the cracks. So if we don't do it now, we're going to lead to more complications that are going to be happening in the future. And we have so many more tools in our toolkit that we can offer our patients now that we didn't have when I started. I go way back before both of you, is that we had metformin, we had sulfonylureas, and then we ended up having insulin. And it was beef and pork at the time. Humulin just came out. So I've been around a long time. And now we have like I had everybody was on glyburide, and now this has completely changed. So there's really how much has changed over this period of time since I started in the early 90s to where we are today. So it's really an opportunity to actually improve the care of these individuals as well.
So let's take a look at some of these guidelines. So you mentioned metformin. That's still the OG, right? It still comes in. It still comes in as start metformin, but there's a little asterisk there that looks at patient-specific risk factors. So it's kind of like there's more nuances now. So you mentioned that there's more therapeutic agents. When we look at diabetes care, we look at also not just glycemic control, but CV risk and chronic kidney disease risk. So I'd love to hear your perspective, Mike, on how pharmacists, because like you mentioned, I think I'm out in BC, and we just got authorized to order lab tests in the summer. There's probably about 10 of us that have the authorization, because with the Canada Post strike, there was some difficulties getting MSP numbers mailed out. But the one test that I'm really hyper-focused on, and we were talking about this before the show, is ACR, albumin-creatinine ratio, because that is part of the plethora of tests that we can order. So looking at things like kidney function, CV risk, how do these agents now, with all these tools, how do we deploy them better?
I think this is where the biggest update has been really in the last little bit. So in terms of managing people with chronic kidney disease and type 2 diabetes, we know the data is pretty solid from the standpoint that more than 50% of people with type 2 diabetes will develop kidney dysfunction over the course of the disease state. It's consistent, and it likely will be higher as these patients are living for a longer period of time. Fortunately, what we know is that I can tell you is that Diabetes Canada is in the process of updating. They presented at their conference an update in terms of their CKD chapter is likely to be coming out shortly. So that will be the next thing of that basis. But let me give you some of the key things that I really want to let people know that have been updated. So first and foremost, we don't have that chapter yet, but in the meantime, we have the Kidney Disease Improving Global Outcomes, or KDIGO. They made guidelines and management of kidney disease and type 2 diabetes probably about a year and a half ago. It's really good. It's like a pyramid that showcases what these patients should be taking. And they really focus on the pharmacotherapy. So for these individuals, there's kind of a holistic approach, and we'll talk about first-line agents, but they really recommend for all patients that they should be on an SGLT2 inhibitor, they should be on an ACE inhibitor and ARB, not just for the standpoint of lowering their blood pressure, but improving kidney outcomes. And then all these patients need to be taking a statin. Statins, wherever the kidney goes, the heart goes. So we need to actually protect the heart as well. So SGLT2 inhibitor, statin, blood pressure control, and ACE inhibitor are recommended for these individuals. One that's actually changed recently, and pharmacists may be aware of it if you've had any blood tests or you looked up blood testing for patients, is that there's a new push for the kidney risk failure equation, or KFRE. You may hear that terminology. And I was really lucky. I had the pleasure of working with a nephrologist, Dr. Tangri, who's based out of Alberta. And he's done like just incredible work with his team to actually look at how can we predict the risk of kidney failure in individuals. And they come up with this incredible formula that really just looks at ACR, so albumin to creatinine ratio. So this is a urinary test. If you pharmacists are not familiar with, is how much albumin is spilling in the urine in comparison to how much creatinine is being spilled in the urine. Then we have estimated glomerular filtration rate, where eGFR, which is based on the serum creatinine level for those individuals, a couple of formulas for it. Their age and their gender, and then where they live. And they can tell you what's the risk of progression of an individual at 2 years and 5 years. And all of this is available at kidneyfailurerisk.com. And what I loved about it is that you can actually plug it in for the patient, and they will actually say, hey, if you just actually put this person an ACE inhibitor or an ARB, you lower their risk. So if they're 5%, you put it in, it's going to lower their risk by X. If you start them an SGLT2 inhibitor, it'll lower that risk by this amount. So it's a really great tool of what can I do to actually get that patient's buy-in? It's, hey, listen, let's lower your risk because I don't want you to get to dialysis or kidney failure, which is what it's assessing already.
Yeah, no, I think I really like that tool. I think you sent some the link, and we'll definitely post that in the episode notes. It's a really cool. I love the visuals too. The visuals are really nice with the actual kidney infographic, and I agree. I find that the GFR now that so just to give some context, in BC we've had access to lab results through Care Connect since 2021. And now we can order it as of August of 2024. So what I find is a lot of patients do have up-to-date eGFR, but they don't have up-to-date ACR. So we actually I had a few pharmacy students, and they're great for this, to data mine your system for patients for workups. And we found that almost no patients had an ACR in the past 18 months that were all diabetic. So like you mentioned, albumin is a protein and it should not be showing up in the urine because it's pretty big. So that means there's some damage to the kidney. And I don't know, correct me if I'm wrong, but I was on a webinar with a nephrologist out in BC, and actually patients can have a normal GFR, normal-ish, but their ACR could potentially be quite elevated. And that actually is a bigger predictor of cardiovascular risk. I don't know if I interpret that.
Yeah, it's both of these, right? So if we look at outcomes, so KDIGO in their guidelines, they actually have a heat map that they generated. So, and they look at it based on you're using your ACR levels, or how much albumin you're spilling in the urine, and then your eGFR, so how high your serum creatinine is based on those calculations. And basically, the lower your eGFR gets and the higher ACR gets, there's an increase in cardiovascular disease and kidney risk progression. So you can have a patient that can end up having, a mildly decrease. So say somebody with an eGFR sitting around 55, 52, 55, but having huge amount of protein that's spilling in, that person's risk of progression, as would be shown by that tool, will actually be higher than somebody that actually is low on both of those ends. So you have to look at both of those figures. And for people like John and I, who were in Ontario, they'll say, well, Mike, I don't have access to labs. You know what the nice thing about ACR is? It's really good, is you can just look at any person with diabetes is, when's the last time you peed at the lab? And if they say, well, I haven't done that for a long period of time, then you need to get that patient in for an ACR reading. So it's an easy one to actually let them know. And it's something that's constantly, as you said, constantly missed.
And it's, Mike, it's funny you said that. And, as Ajit was, speaking there, I was starting to think about the inconsistencies in scope, right? So, we're a little bit behind BC in this perspective. So we've got the ability here to look at lab values, but that's what I find as well, Ajit. You go in there and, depending where you are, I mean, and coming out of the pandemic, sometimes there's a lot of information, but most of the time there's not a lot, right? A lot of these patients haven't seen especially in the area that I practice in, they haven't seen their family doctor. They don't see them regularly. So a lot of the info there is old and dated. And we, unfortunately, in Ontario, we don't have the ability to do what you guys are doing there and, send them out with a lab rack. I mean, we have some point of care testing technology available that's useful, but it's still really limited, right? We can't do everything. So it'd be great to see us, as I listen to, Mike speak, I'm like, shit, man, this is such an opportunity here for us to get some more scope, right?
Yeah, and I think that, John, like one of the key things here is, and I think it's really important as we start to look at this stuff, is that we shouldn't be blaming anyone in terms of this. So please don't blame the patient, don't blame the primary care clinicians that are here. This is an integrated issue that a lot of times from a healthcare perspective that we all have to work as a team, including the patient, to actually manage those bases. So it's an opportunity. Like I look at the thing, so to Ajit's point, if they haven't had an ACR in 18 months, that's really an incredible opportunity to see where they're at versus, I can't believe this person didn't get this done. Who are we going to blame for this? It's not really the issue. And to your point, with the pandemic, it's been a real challenge for many of these individuals that are at, especially some of the high risk, more frail patients that are actually going to be more difficult to get into the office.
Yeah, you know what? There's two things that come to mind when I see these gaps, and it always puts the patient at the center. One is, are they walking around at risk for macro or microvascular complications? Are they leaking protein in their urine and they don't even know it? And the second is, are they on the right medication regimen based on the guidelines to address it? So those are the two things that always that pop into my head. And I think that's really important as pharmacists because we see the patients. And Mike, we've talked about this, John, we've talked about this, like they see us regularly refilling these unoptimized meds, if they are in fact elevated with these parameters that are being measured. So it's a very logical fit that a pharmacist should be looking at labs with the intent of interpreting it to match the latest guidelines to adjust their medications so that they can take said medications to have better outcomes. So it makes complete sense. And I think my advice to Ontario from BC is we've just started this journey. So Alberta's been doing it for a while. There's still an opportunity, Mike, like you said, like there's still these gaps. You still have your diabetes meds check in Ontario. You can still help people. And when you start getting these tools, now you can integrate them quickly. So I always say to pharmacists, I can't do this, or I can't recommend this vaccine because I can't put it under my name. When the day comes when you can, you're going to be a lot better off and a lot more comfortable off to the races when you've been doing it before and doing the heavy lifting of those conversations. So a lot of value to this stuff that we'll be talking about in this episode and the next one. But Mike, I wanted to turn it back to you about, let's talk about kidneys and let's talk about meds for kidneys. So obviously metformin is like the OG, and there's individual nuances for chronic kidney disease. There's SGLT2 inhibitors. There's also other medications to help with reducing renal decline, reduce the incidence of end-stage renal disease. And there's some recent data from even medications like semaglutide, where that also has, I like to call this pleiotropic effect, right? So even if glycemic targets are good, there's still benefit to these patients in these studies to reduce CKD decline and end-stage renal disease. So let's talk a bit about these agents and where they all fit.
I love that the terminology. Like the key thing with this is that we're looking at risk reduction. So to your point, it's not necessarily about we need to get this person to an A1C target, and this is the reason we need to add these medications. And this also applies for drugs like statins or ACEs and ARBs. We add them not for only the lowering the blood pressure, but even if they have normal blood pressure, normal cholesterol, we need to add a statin and a blood pressure medication or an ACE and an ARB to reduce their risk of a heart attack or stroke. This is kind of where we're moving through with CKD, is that if you look at it, the original studies that we end up sawing, so we had EMPA CKD and we had DAPA CKD, and those two trials really, and then we had credence from the standpoint with canagliflozin, looking at the components of SGLT2 inhibitors, and they changed the course of these disease states. And that if we start these patients on these drugs, regardless of what their A1C level is, with your original metformin OG, we actually can maintain the kidney function for these individuals where the kidney doesn't actually decline as quickly. They'll still decline, and we are all declining, but we'll see a reduction of that component. So we may be able to prevent dialysis and long-term outcomes. And so there's a real positive. So if you start to see, and then from a pharmacist standpoint, from intervention, if you have any access to labs, so even Ontario, many of us can actually look at laboratory data, but not necessarily order it. And that we can actually come up from the standpoint and actually see, hey, this person has an eGFR of this. I know they're on metformin, so I know they have type 2 diabetes. We should be looking at starting off an SGLT2 inhibitors. The medications we would use, you can use canagliflozin at a dosing of 100 milligrams, DAPA at 10, or empagliflozin at 10 milligrams. Question always comes up, should we use the higher doses? The CKD production was all shown with the lower doses. So it's 100, 10, 10. It's easy from that standpoint, and they're maintained long-term. I get pharmacists that get really anxious about, when should I discontinue if their kidney functions? We keep them going until the person goes in dialysis, and hopefully that's a very, very long time. So they start it and they stay it on long-term. The newest data are actually with two other agents. The first one is GLP-1 receptor agonists, and really the data has been with semaglutide to your point, Ajit. And this comes from the FLOW trial. And the FLOW trial, and I'm not going to go into all of the details of it, but essentially, if you think about it, these are patients with a reduced eGFR and an elevated ACR. So we talked about those overall components. And they were giving these patients, either you would get semaglutide, 1.0 milligrams, or you would get placebo once weekly of those individuals, and you would titrate up as normal. They ended up stopping the study early because so many more people were actually getting the benefit with semaglutide as what we ended up seeing with patients that were getting placebo. And you know what are the numbers? Well, they did the base of the trial was done at week 156. And then they actually had week 104. So if we look at what the primary composite kidney outcome for these patients, which was greater than 50% reduction in eGFR, onset of kidney failure for those patients, so it's really of those basis, or persistent eGFR less than 15, death from kidney failure or cardiovascular disease. So they put those all together and that becomes your composite outcome. We saw over the course of this one is a 24% reduction, so a hazard ratio of 0.76. And what's cool about this, at week 156, we only needed to treat 20 people with semaglutide to actually reduce the risk of this outcome in these patients with type 2 diabetes. So it's quite exciting from the standpoint of what we were able to do. And the only thing that I'm a little bit concerned with is in the trial is that when they started FLOW, not that many people with chronic kidney disease were on SGLT2s. There was only about 15% within that overall group. But they did a sub-analysis of that component, and we saw the benefits both in patients that were on SGLT2s and not on SGLT2s. So the benefits are across those components. So right now, I think you're going to start to see SGLT2s being first, but we're going to start to see semaglutide being used consistently, even in patients with normal A1C levels. So we're going to start to see that overall component. And what I do like about that is that the additional benefits that we would see by using semaglutide 1 milligram, which is the dose they used in this trial, or 2 milligram, which is approved here in Canada, we're also going to see improvement in cardiovascular risk factors such as weight, blood pressure for those individuals as well. So it's going to have multiple benefits across that basis. So I think this is where we were SGLT2s 2 to 3 years ago, is where we're going to be with semaglutide moving forward. The only other drug I really want to talk about is really what finerenone is. And finerenone, if you're not familiar with it, is think about spironolactone that we use in heart failure. This is actually a non-steroidal MRA. So it's a mineral corticoid receptor antagonist. They did trials. So there's 2 trials that were done looking at renal outcomes in patients with type 2 diabetes and chronic kidney disease, and they looked at cardiovascular death. And in that trial, same thing, that patients that were actually spilling a fair amount of protein or albumin that was in the urine, and they had kidney disease, we were able to reduce the risk of actually having death from cardiovascular causes or an improvement in terms of renal outcomes. So it really, we're going to start to see that being used. Now, the one thing that is a potential highlight is for all of you pharmacists, we're all kind of geeky about it. We know spironolactone will increase potassium levels. Patients are already on ACEs and ARBs, so we can see potassium levels go up. And if you have chronic kidney disease, what happens? Your potassium starts to go up. So we just have to monitor potassium. So if you have one in your scope of practice and you see patients on this, we want to make sure the potassiums are not going out of whack. And then within the KDIGO guidelines, they actually have recommendations of what to do when patients are running above, a 5.2 in terms of their potassium. What do you do in terms of dietary, or how do you adjust those pharmacotherapy as well?
Yeah, it's a really good resource, Mike. And so, first of all, I just want to say there's so much excellent clinical content that was jam-packed in those past 3 to 5 minutes. The benefit of having this as a podcast versus a webinar is if you're listening to this while you're cleaning your house, you're driving, go back and rewind that and listen to it 2 or 3 times. I know I am. 2 things I want to highlight is one is that potassium management. So as we start, and that's what I'm learning now when I'm starting to use the lab tests, is looking at what should I be monitoring. But also, like, what am I going to do about it? That's like the big thing is, like, you are now, if you order a test, you are now listed as the person to call if there's a quote unquote emergency. Thankfully, for chronic disease management, if things are elevated, it's not acute, like someone's testing positive for MRSA or anything like that. But that potassium Kadigo, and I remember the Kadigo sounds like Kygo, who's like an EDM artist. So, so that's a really good resource to help manage that if you find that. But serum potassium, really important to monitor for a lot of chronic disease patients. The second thing is, Mike, you alluded to this so-called noise in the clinical trials, right? So it's great that with the SGLT2 inhibitors and the benefit of semaglutide, it was able to take the SGLT2 out and still see the benefit, if I'm not mistaken. Versus metformin, so much noise with metformin, right? With the current pharma guidelines, because so many patients are already on it, it's hard to tease out causality, but I think we're getting better at that.
Just to add to that point, that's where everybody comes up and says, should we really be starting with metformin? Is a question that comes up all the time. And you mentioned it multiple times where it's the OG. And the reason why is it's cheap, it works, it's persistent. It's been shown to be highly effective. It reduces outcomes over the long term. But the fundamental thing is that all of these trials, those cardiovascular outcome trials that have been done with these drugs and the renal outcomes trials are all with a background of metformin. So without that, I can't tell you if I use an SGLT2 without metformin or I'm using a GLP-1 without metformin that we're going to really make a significant difference in type 2 diabetes, because that's just not seen within the trials. So that is why still to this date and probably for the foreseeable future, we'll be using metformin as a first-line therapy for almost everybody moving forward.
Definitely. And I always say, like, there's value, and I say this to pharmacy students and new pharmacists, there's always a value for intervention for that first fill of metformin, because a patient comes in and they feel they weren't given adequate time to do diet and lifestyle, which, you have, that's great, but you had 3 months and it didn't help. So now we need something to help it. So I think adherence is really important. And the other one is tolerability. I find a lot of times we could taper the doses a little better, where now somebody had a bit of GI upset because they took 500 instead of 250. And I always counsel patients to take it slow. Because I don't want to lose that agent. I go back retroactive a lot of times, patients, when we review them and they're not on metformin, which I think is strange because we talked about it, tried, tested, and true. And they had some tolerability issue like 3 years ago. So you could probably even reintroduce it a bit slower. So it's a really good thing to look at in clinical practice. It can make a huge difference longitudinally for a patient.
And to your point, is like that titration is so important for that initiation. But we also have the XR format for people that have private coverage that can actually reduce the GI, because it's GI-related adverse effects are the most common things that we end up seeing with it. So most of the time, if we can manage that for the first 3 to 4 weeks, the patient is actually going to be okay. So it's actually picking what that right regimen is going to be. Slow titration or using an XR format can actually make a huge difference. But even just telling people to take it with food, that's something that's missed by a lot of patients and they don't necessarily get it. And the other thing is an education point, if you want to highlight, if people are worried about starting metformin, I really didn't get a chance. I can just tell you from the data is that we know that by the time you're diagnosed with type 2 diabetes, 50% of your beta cells are gone. So you've already lost that component. So even if you do everything perfect, you're starting in a deficit already. So you're really thinking your engine's 50% broken. The issue is that we a lot of times use that metformin because what we want to do is get that glycemic control under control so we can maintain what little that beta cell protection that we are, beta cell function that we have. If we still have high levels, more beta cell death, harder and harder to get that patient under control. So that's why we really want to start these early. And I have many patients, as soon as they're diagnosed, they're not given them 3 to 6 months, they're just initiated on metformin and then encouraged to still maintain those behavioral changes because they're an addition to, not in place of. So we can use it with metformin as well.
So Mike, I wanted to ask you, because I think, going back a few years, we talked a little bit about the onslaught of new agents and kind of some of these new tools. I remember doing some work in the early days where kind of one of the things we found is patients were delaying therapy. They didn't want to go to insulin. They didn't want to, inject themselves. So we're taking a real kind of reactive approach to diabetes. We're kind of waiting till they get worse, trying to convince them to go on insulin. They didn't want to. We would add agents. It wouldn't improve. With the guidance the way it is now, do you think that's going to change? Is insulin going to be used less frequently in this type 2 diabetic population? I know we were trying to promote more insulin use at one point.
It's a great question, John. So the issue is now that we have highly potent agents. So if we look at the GLP-1s, specifically receptor agonists, and the GIP GLP-1s dual agonists, receptor antagonist, for that, or agonist, from that standpoint. These are highly effective agents. And if we initiate those earlier, we're going to end up seeing probably a reduction of really need of using insulin early in the course of the disease for patients. But what we're seeing is that we know that beta cell function will decline over a period of time, and almost every pharmacotherapy that we use for the management of diabetes requires beta cell function to be there. So the longer we live with diabetes, the higher the chance that we're going to end up using insulin over that prolonged period of time. And the good news is that by using insulin in combination with all of the other therapies we have, we can usually manage with just basal insulin. So one insulin dose that would be given either daily or weekly that can actually manage these patients to control the fasting glucose, that background, where we can use the agents to actually help for the postprandial or after meals. So that's what DPP-4s, GLP-1s, and all those focus on as well.
So, Mike, I heard you say weekly insulin. So this must be something new, because again, I graduated from Leslie Dan a little bit after both of you, and that was definitely not in the curriculum. So tell us a bit more about this weekly insulin.
A little bit after me, it's okay. It's a lot after me, you could say it. But no, so the insulin is really cool in terms of what's ended up happening. So we've actually gone through, so we started with NPH insulin. So if you're not familiar with what NPH insulin is, what they do is they take regular insulin, they combine it with protamine to give it a little bit longer action. What we then moved into these analogs, so we adjusted what insulin looks like to change the properties. So that's where you have first generation. So this is where you see the drugs that we had, insulin detamir and glargine U100 were the first generation, moving into degludec. Then we had glargine U300, which is the second generation. Now we're up to weekly. So insulin icodec has actually just been launched within Canada. It's kind of cool in terms of the way that it's actually administered. It's, again, if you're a geek with in terms of how these work, is that you administer this complex and it sits within the subcutaneous tissues and it binds in here, and then it slowly releases it by binding to albumin that's circulating through the bloodstream to give it a really long mechanism of action. So the duration of this one's about 196 hours. So it's approximately about 1 week. So it's one injection per week for them, and which is really quite exciting. To your point, John, we were really worried about injections, and patients would never accept it. And I'm finding that what's funny is that as healthcare professionals, we were more worried about it than a lot of times what patients were. Like, oh, my patient would never inject this. But as soon as we actually introduced GLP-1s and we told them we could lose weight, now everybody will inject. So I think that with this issue is that what I like about this is we have so many patients that are actually using GLP-1s. And if they can't maintain their targets with those agents, this could be something that can be added in fairly easily. And it's a once weekly dosing that's actually given to these individuals that's titrated over that period of time. What's scary with this is that it's kind of freaking out of some of the people when they started, because you think about, okay, what's the starting dose? Well, we start basal insulin. We start at 10 units daily, and then we adjust based on fasting blood glucose, as that's what we're targeting. With icodec is we're giving 70 units, but that makes sense because it's weekly. So 70 units is 10 times 7 is 70. And then what we do is we increase it by 20 units at a time, based on your fasting blood glucose reading. So it's an average fasting blood glucose readings 2 days before, 1 day before, and the day of your next injection. So you take a little bit of those 3 readings to be able to adjust that component, and you move up and down. So 4.4 to 7.2, you don't do anything. Above 7.2, you increase by 20 units. Below 4.4, any episode of hypoglycemia, you drop by 20 units. And it's fairly straightforward, and it's just added on in terms of that overall component. And I don't know if you want me to talk about a little bit about switching. So one of the things that we're seeing is that it's really freaking people out is that you would come up and you would take, if you're going on, say, patients on glargine U100, so they're taking a product called Lantus, and they were actually administering, say, 50 units at a time. And you think, that'd be a patient that'd be really good for weekly insulin. So the thought process is that when we switch from daily to daily, we usually go around the same amount. So sometimes we'd be conservative, drop by 10% just to be careful, just in case there's some differences with it. But because this is so slow acting, that we actually give a bolus dose. So you take whatever dose that they're taking on week 1, you times it by 10.5. Then rounded to their overall basis. So it's being 50 times 10.5. So in a case, I use an example, say, of 20 patients that is using 20, they would be taking a total of 210 units that first week, followed by 140 or 7 times that unit week 2, and then it would adjust accordingly. So I have people freaking out because these could be people that are taking 400 to 500 units of insulin that first time that they're actually checking it. So they get a little bit nervous about it, but this is actually what was done within clinical trials, and it looks okay. So Those are the two things, and we may see that basis. So I think as pharmacists, we may panic a bit when we see it, but it's usually generally going to be fine. And that's what's actually shown with these onwards trial that was done with insulin icodec.
Wow, that's a fantastic overview, and I think we'll see more with weekly insulin and insulin icodec with future updates of the Diabetes Canada guidelines, because it didn't quite make it into this last one, but they did mention it. So maybe John and Mike, a future episode when we have some more guidance.
Well, the key thing, though, from that point is we don't necessarily have to have it even within the guidelines. From my standpoint here is that anytime you would use insulin for a patient with type 2 diabetes as basal, you can consider insulin icodec regardless of in the guidelines. All insulin are equally effective. It's just really of, the properties of how long they're acting and how well they tolerate, and then coverage and other issues come into play as well.
So, Mike, did we hit on all the pearls in those guidelines, or are there other things that we may not have talked about yet, or maybe missed?
Yeah, the only thing I would actually add to this one is if you have a chance to look at, and we'll share the link to the guidelines, but the actual figure, the algorithm for type 2 diabetes is so much simpler now. So if the person is at high cardiovascular risk, heart failure, chronic kidney disease, you have clear recommendations of what those can be. If the patient is actually, metabolic decompensation, so they're actually spilling so much of this component, unintentional weight loss are so high, we start insulin and then cut them back. All of that is covered really nice in the guidelines. So I think it's really clear. And then what I do like about the guidelines for pharmacists is that as we're getting more lab values, they rate within that chapter. They have recommendations of how to adjust anti-hyperglycemic agents for patients based on eGFR. So if you have their eGFR and they're on metformin, it's like, oh, do I need to adjust the dose? All covered within the guidelines. It's really, really clear in terms of the summary. So I would encourage you to take a look at that component as well.
Perfect. Well, that will be posted in the show notes. Thank you so much, Mike, for that excellent update. And it's just great to get that clinical update, because the next step is application. And it's important to listen to this episode, because all of those pearls, we're going to talk about how pharmacists can actually integrate that into their practice in the next episode. So thanks, John. Always a pleasure. And thank you so much, Mike, for your wealth of wisdom. Like I said, listen to this on repeat. You can do that with a podcast. Till next time.
Thanks so much for having me there, Ajit.
Now